Okay, so my topic today, as Dr. Potash said, is Arfid, and I'm going to kind of give you a tour on what we know, which is limited. I mean, this is a relatively new diagnostic group. Here are my objectives. I'm going to cover a little bit about the definition of Arfid. Oh, I'm sorry. There we go. Okay, the definition of Arfid, epidemiology, etiology, what we know about treatment, and kind of what next. So just a little bit of history. The reason why the DSM-5 includes Arfid is really based on kind of some historical precedent that has to do with DSM-4. So in DSM-4, there were two categories of diagnoses that had to do with eating. One was feeding disorder of infancy or early childhood, and the other was the more traditional eating disorders, anorexia nervosa, bulimia nervosa, and eating disorder not otherwise specified. The problem with this system is that the first category, feeding disorder of infancy, was rarely used. And in the second category, EDNOS comprised the majority of cases. So the decision of the DSM-5 committee was to merge feeding and eating disorders, to create feeding and eating disorders as one group of diagnoses with three subcategories. Binge eating disorder was pulled out of EDNOS, so there's now anorexia nervosa, bulimia nervosa, binge eating disorder, and then there's this still a catch-all category, other specified feeding and eating disorders. And then Arfid was used to take the group of patients who are atypical in the sense that they don't have body dissatisfaction and combine them across the lifespan from infancy to adulthood. And then there were two remaining categories of pica and rumination disorder. And sorry, I just wanted to show you that as a result of DSM-5, which occurred around here in 2013, there's been a marked increase in publications on Arfid. So we are accumulating information, just not as fast as we would like. So here are the DSM-5 criteria. They include eating or feeding disturbance that results in failure to meet nutritional or energy needs. And that includes at least one of the following areas: weight loss or growth delay, nutritional deficiency, dependence on enteral foods or liquid supplements, or psychosocial impairment. And that is not attributable to cultural reasons or food scarcity, that does not occur in the context of a more typical eating disorder, and is not driven by body image disturbance, and that is not attributable to another medical or psychiatric disorder, or if another medical or psychiatric disorder exists, its severity exceeds that expected. And as I mentioned, there's no age limitation. You can have Arfid regardless of age. And there are no weight criteria. So Arfid does not necessarily imply underweight. You can actually be normal or above normal weight and have Arfid, because it's really, in terms of low variety of foods consumed. We don't know the estimated prevalence in the community of Arfid. There are no good epidemiological studies. Studies in pediatric populations seeking GI care suggest that up to 3% meet criteria for Arfid. And we know that disordered eating in general and Arfid are more prevalent in children with intellectual disabilities or autism spectrum. And at least one study of an adult GI motility clinic found rates as high as 6% in adults presenting with GI dysmotility. In eating disorder clinics, we actually see the highest percentage of these patients, with up to 20% in programs like the one here, meeting criteria for Arfid. So these are not new cases. We've been treating them all along, but we have a name for them now that we didn't have before. And DSM-5 distinguishes three potential subtypes. They would be Arfid limited intake with low appetitive drive, which our patient today would fall most into. Arfid limited variety, which includes a lot of kids on the autism spectrum who may have trouble with textures or consistencies or smells of foods, and narrow their food preferences for those reasons. And then Arfid aversive, which usually is Arfid developing in response to some kind of event and linked to anxiety about eating for fear of the same thing happening. For instance, an episode of choking, food poisoning, or abdominal pain, or an allergic reaction, anaphylaxis, for instance. So the problem with these subtypes is that they overlap, and it is unclear how one can really distinguish a significant proportion of patients. In fact, the majority of patients will actually fall, or about 50% will cross more than one subtype. The most commonly used screening instrument for Arfid is the 9-item Avoidant restrictive food intake screen, which has been used in both children and adults. There are other ones, but I think this one's the simplest one to use. And it has 3 subscales, namely, the first is the sensitivity subscale, so I'm a picky eater, or I dislike most foods that other people eat. The second is the low appetitive drive subscale, and the third is the Arfid aversive subscale. And a score of 10 on this first, 9 on this one, or 10 on this one, based on these answers, which go from 0 to 5, meets criteria for Arfid. But the sensitivity of this test is good, but the specificity is not, meaning typical eating disorders often will score high too. So you have to use something else to make sure that you don't think the patient has, for instance, body dissatisfaction that would more closely meet anorexia or bulimia. And here you can see, this is a study of approximately 100 youth with Arfid. You can see that a significant proportion are falling in these intersecting areas. In fact, a total of about 50% will therefore not neatly fall into one of those 3 subcategories. And this same study actually looked at comorbidity too, and what they, just to kind of walk you through the sample, these were, I don't know if you can see this, but these were both children and adolescents. So there's children over here and adolescents here, pretty equally half and half of each. And they also, sorry, to get used to this mode, they were pretty evenly split by sex. About half were female, and pretty evenly split by underweight or not underweight. And amongst this cohort, the psychiatric comorbidity was high. It was about above 75%, with the most prominent other diagnosis being anxiety disorders. And this is a pretty consistent finding across studies. This is actually a relatively large study. Most studies of Arfid are small, like 10 to 30 individuals. So I'm just showing you kind of the larger studies. So anxiety disorders is the most common comorbidity, but you also see elevated ADHD, autism spectrum, and depression. And this study, which is a Canadian study that came from an adolescent medicine program, looked at a similarly sized sample of about 77 teenagers. And they divided them by subtype, so predominant subtype here, with about equal numbers in each group. And a significant proportion were underweight, so we're around the average target. The average weight was about 83% of target at admission. And again, you see that anxiety disorders are the most common comorbid condition across all 3 subtypes, occurring in close to 50 or higher % of cases. That developmental disorders are actually more prominent in this cohort, so you see more autism spectrum or other developmental delays. And mood disorders is actually relatively low. So the incidence of mood disorders in Arfid is actually lower than in anorexia, but it's still present. What about quality of life? This study from Holland was from a pediatric cohort. So this is not a psychiatric group. It's a pediatric kind of failure to thrive clinic. And what they found is that children with Arfid, this is a typo, it says I don't know what it says, but it should say Arfid, were compared to a reference group of healthy kids, age-matched kids, or to chronically medically ill cohort. And what they found when they divided the groups into 6 to 7-year-olds, so really latency age, child versus latency age, 8 to 12, the quality of life was impacted in the younger cohort significantly, and more so than in the healthy population, and equivalent to the kids with a significant medical comorbidity. So there's quite a big impact on quality of life. And when they looked at school functioning, that was impaired in both cohorts, both age cohorts, and was higher actually than in the medically ill group. So it is important, I think we heard this from our patient today and his mother, there's something chemically wrong in some of these patients, but even in those who develop, for instance, the aversive subtype after a choking episode as adults, because of the change in eating behavior and in food ingested, whether it's not enough food or a problem with variety, most patients we see have a disorder of gut-brain interaction. And that's either a consequence or a cause or both. So we have this kind of bidirectional relationship between GI symptoms and eating disorders, whereby one can cause or aggravate the other. And that's true both in terms of aggravating anxiety, for instance, or fear of eating, which results in dietary restriction, psychosocial effects like worrying about eating in social settings and therefore becoming more isolated, and GI-specific motility disorders or changes in appetitive and gut signaling that may promote or maintain the disorder, as well as medical consequences or comorbidities and neurosensory changes that may predispose or result from changes in eating. So when assessing a patient with Arfid, it's really important to rule out other causes of the problem. And this is especially true for patients who, unlike our patient today, don't have a lifelong story. But even in individuals who have a lifelong story of poor appetitive drive, you can have some kind of insult or secondary medical problem that is exacerbating the already low weight and appetite. And the most common things that we see are the following list. So whereas in anorexia, for instance, if a patient is clearly presenting with the kind of typical signs of anorexia, meaning fear of fatness, and then a division of foods into good and bad foods based on calorie density, here the types of foods that are avoided are often very much more idiosyncratic. So it is more important to make sure that you're not missing any medical problem. We have seen at least 2 cases admitted to our unit of achalasia in the past year, which was not diagnosed. We've seen many cases of eosinophilic esophagitis that worsen perhaps a pre-existing level of an eating disorder. And we also see inflammatory bowel disease or celiac disease in a significant number of cases. So thinking outside the box and making sure that there's no GI problem is an important, perhaps more important to keep in mind than in anorexia, especially when a patient is not responding to treatment. Okay, another question is, can Arfid develop into a more typical eating disorder? We do know that about 12% of individuals with Arfid, especially females, go on to develop anorexia around puberty. So there certainly is a group of patients with anorexia who have premorbid Arfid. And whether you can go in the other direction, in other words, whether anorexia as a teenager can later become Arfid, we don't really know. Usually cases who present saying they have Arfid with a history of anorexia actually turn out to have anorexia once they reach a BMI of about 18. They actually are more forthcoming about having fear of further weight gain. But there is the occasional exception, so we just don't know. But certainly it's possible to move from one to the other, at least in the direction shown here. As I mentioned, Arfid occurs across the lifespan, but there are certain times in life when you are more likely to see problems with eating. The first, obviously, is in infants with the transition, actually to start with bottle or breastfeeding, so actually latching in the newborn. And we heard our patient today had trouble with that really from birth. But the second time when we see problems is around weaning or transition to solid foods, so around 6 months to a year and a half. And then in preschool and early childhood, you have a kind of window of opportunity to broaden food choices because kids are eating with other kids and then with other adults and are exposed to more foods. And the same thing happens in adolescence. Often patients seek treatment in adolescence because they feel awkward about, for instance, going to college. What am I going to be able to eat? Because I only eat Noble Roman's pizza, for instance. And then, of course, illness and stressors can worsen the problem. And we heard that today, how the COVID pandemic really kind of interrupted the regularity of eating and resulted in skipping more meals. Not good at this clicking. Okay. So I'm going to just briefly talk a little bit about feeding disorders in infancy and early childhood. This is not my area of specialty, but we have a wonderful program here at KKI that really works with kids this age. But to understand the problems with children, I think it's helpful to understand a little bit about the evolution of food preferences in the healthy child. And we know that there's an inborn preference for sweet and salty tastes and a rejection of sour and bitter. Sour and bitter tastes are learned. And you learn food preferences as an infant based on the association with context and consequences. In other words, if everyone else is eating it, kids are more likely to taste it. If you live in a family of picky eaters, you may be less likely to have a diverse palate, and that may be partly genetic, but also partly exposure, obviously. In infants, during the transition to solid food, it usually only takes one taste for an infant to accept a new food. They're interested in new food. They're open to whatever you feed them. However, when they start walking, the average kid becomes more tentative about trying new foods. Maybe that's an evolutionary protection against putting everything in your mouth, but we know that we often see patients presenting to treatment more at toddler age. That's when these problems sometimes arise. Children will typically self-select well from a buffet of food, but not if processed foods are provided. They will favor processed foods if given the option, and that's often the food choices that we see favored in kids with Arfid. Studies have shown that social factors shape what children's food preference, but telling a kid something's healthy doesn't work very well. Telling them that it tastes good works better. But I have to admit, it doesn't always work. My kids still make fun of me and say, whenever I use this fried like zucchini and say, tastes like French fries. So it's a big joke in the family. Everything tastes like French fries when they don't really like it. So The other thing, obviously, that influences palatability are post-ingestive consequences, and they can especially contribute to aversions. I mean, there's still one food I won't eat because I had food poisoning as a child from it, and I'm sure other people here have had similar experiences. The problem in Arfid is that often generalizes to most foods. I want to briefly mention pediatric feeding disorder. This is another diagnosis, and it was created later than the DSM-5 Arfid diagnosis by the pediatric world, because of course feeding disorders in infants is often treated by pediatricians primarily, not psychiatrists. And what the reason that they created this disorder, this diagnosis, is they felt that Arfid doesn't take account enough of developmental or medical problems that impair eating, like cystic fibrosis or severe autism. And so this, in a way, is a diagnosis that takes into account medical problems more, as well as skill with eating. So, for instance, kids who can't feed themselves or have trouble. So it's more relevant to the peds world. And in terms of kind of data coming out of pediatric feeding disorders clinics, most of the data is based on case studies or case series. There is really only one randomized control trial I could find, and it's only a pilot study that looked at trying to get kids off enteral or liquid feeds to get them to eat solid food. And this is pretty close to the approach, I believe, that's used at Kennedy. And the program was called I Eat. It used the parent as the feeder. It was a multidisciplinary day treatment, 5-day program, where the staff really trained the parent to feed the child, really to spoon feed the child. This is obviously young children, by choosing 8 standard foods, 2 per food group, and having a schedule of weaning the formula they were on over the 5 days and increasing the PO intake. So they started with pureed foods, then added more texture over time, and collected information using an iPad on things like frequency of bite acceptance. And the majority of parents reported they felt they benefited from the treatment. And it's pretty close to what is actually done in most feeding clinics. This study was actually from another feeding clinic that used a very similar approach and looked at who did not benefit from this very behavioral approach for very young children, and found that the only negative prognostic factors were the most selective eaters were harder to get to diversify their intake. Those with intellectual disabilities, not surprisingly, male were harder to treat than females. But the majority still improve, with about 73% improving. So what are the medical complications of Arfid? Well, obviously the most common one in kids is poor linear growth or malnutrition related for those who aren't underweight but may eat a very limited repertoire. The question of osteoporosis is somewhat unanswered, and I'll show you a little bit of data on that. You know, do underweight Arfid individuals at risk of osteoporosis like they are in anorexia? Obviously, GI symptoms are a prominent complication, and GI dysmotility. Dependence on tube feeding or liquid diets. And one of the things we don't know yet is how much rate of weight loss is relevant to medical complications, but presumably it's important because we know it's important in eating disorders. And in Arfid overall, it looks like studies that have compared Arfid to anorexia on medical complications, and there's very little information on very small cohorts, show that overall, Arfid cases have less lab abnormalities and medical complications, probably because most of them are stably at a low weight and haven't lost weight recently. So here's a study that tried to look at risk of bone loss in in Arfid, and these were female youth. And you can see that in the Arfid cohort, there is lower bone density at all 3 sites, but it's still not meeting criteria for osteoporosis. It's actually not close to 2 standard deviations for the most part. So although it may be statistically different from the healthy controls, it's unclear if it really rises to the point of osteoporosis. But an interesting other factor was that loss of bone density was inversely related to PYY, which is a hormone that induces satiety and inhibits bone formation. This is a small cohort. It has not yet been repeated, so we do not know really long-term how much we need to worry about bone health. In assessing individuals with Arfid, it's important to look at growth curves. And for instance, here you can see a growth curve of a young man I saw who was very tall. There was no stunting of his height, but clearly he's dropping off in terms of his weight. So in setting a target, we will try to get patients back in this kind of case on their growth curve, which is this line, which is, I don't know if it's the 25th percentile, I can't read it from here. And then similarly, this case, which was a case of a teenager who developed aversive Arfid after an episode of choking, you can see her weight dropped rapidly. She was admitted here, regained to here. We targeted the 50th percentile as her minimum target weight, but you can see that after she left the hospital, she gradually returned actually to the same premorbid curve she was on. What do we know about treatment for adolescents and adults? So I'm going to leave the pediatric world now and just talk about what we do here and what we know so far. Most approaches are based on evidence-based approaches to treating eating disorders, and they mainly come from case reports, case series, and retrospective chart reviews or small pilots. There's really no reasonably powered RCT to date. But they all are using some combination of the treatment basics that apply to eating disorders. So things like regular meals, self-monitoring, exposure, relaxation training, using behavioral experiments around meals to increase food variety, eating in different settings. Most involve families, and many use some level of behavioral contingency management. So I'm just going to run you through 4 of the current psychotherapeutic behavioral approaches to treating outpatients. These are all under study, so they're all currently NIH-funded studies. Now look, they're much more similar than different. They're kind of different flavors of behavioral approaches, but I just want to give you a little bit of a summary. The first is called CBT for Avoidant Restrictive, developed by Thomas and Eddie at the Mass General. The second is family-based treatment for Arfid, which is adapted from family-based treatment for anorexia by Jim Locke. The third is called SPACE Arfid, which stands for Supportive Parenting for Anxious Childhood Emotions, and is a short treatment, only applies to non-underweight. And then FBI Feeling and Body Investigators is for young kids by Nancy Zucker at Duke, and really focuses on interoceptive awareness. So I'm going to show you a little bit of give you a little bit more detail on each one. So the Mass General's cognitive behavioral therapy for Arfid applies to children aged 10 and up. There's both an individual and a family-supported version. It's about 20 to 30 sessions. It's meal-based, so they can't be on tubes. In stage 1, that consists of psychoeducation, regularizing 3 meals, self-monitoring with a food log, focusing on encouraging early behavior change, which we know is one of the best predictors of change in eating disorders and in other behavioral problems. And identifying foods for exposure, doing food exposures both within and between sessions, and then focusing on maintenance and relapse prevention. And in a pilot of 20, it looked like it was a promising intervention. And you can see here a case And again, I don't think you can read it, but this was a teenager who had been out on a date and ordered pasta and couldn't eat it and got very embarrassed, and so sought treatment for that reason. And so they used different pastas for the exposures, but in between sessions they were also using a number of different foods, and you can see that his food neophobia scale decreased over time, and he had a relatively positive outcome and was able to gain weight too. So the second approach, as I mentioned, is family-based treatment. And this, again, is adapted from anorexia. There was a small pilot comparing it to treatment as usual. It's a longer study. It's 6 months. And it really trains families to focus on weight gain if they're underweight, or variety if they're not underweight, as first steps. It takes an agnostic stance as to cause of the eating disorder and tries to externalize the illness in the sense of saying to parents, look, we don't know what causes this, but your child is of two minds and we need to fight the Arfid. They try to create like an emergency of sorts in the family, and then have the parents refeed the child. They had some promising findings, especially in terms of change in parental self-efficacy, parents' confidence in being able to influence their child's behavior. And then the third approach, which I mentioned, Space Arfid, is really focused on it actually only treats the parents, and it's focused on helping parents recognize parental accommodation, ways in which they facilitate the eating disorder in response to the child's anxiety or avoidance. So the goal is to reduce food-related stress and accommodation, things like not buying preferred foods, trying different brands, not bringing food to special events so that your kid can eat there, or only going to restaurants that the child is comfortable in. And then the fourth approach is Nancy Zucker's. This is with younger children, latency age at most, and it's 11 to 15 sessions of CBT, in which they teach kids using these cartoons to identify different autonomic or visceral sensations in order to help them have better interoceptive awareness, and awareness that a lot of these sensations are normal, not pathological. So you see here like Betty Butterfly for butterflies in your stomach, Gaggy Greg for fear of choking or feeling like you can't swallow. So they try to help kids name different sensations and master fear over them. Okay, so what about inpatients? Well, very briefly, a recent review listed 7 current studies. One of them was from our group. These are just correlational studies, but pretty much most programs are using similar approaches. And that is to have a gradual increase in calories. Most programs prioritize meal-based feeding over liquid supplements or NG tubes, but strikingly 5 out of the 7 programs were using NG tubes at least some of the time, and one study was using TPN, and one was routinely using phosphorus supplementation, but the risk of refeeding is probably significantly less in most cases of Arfid, so we don't usually recommend that. So in terms of what we've published, we've looked at 2 cohorts. One was an adolescent group, adolescent and young adult, and that's this study that was led by Sani Hamaksumi, our fellow. And these were, we found that most cases tended to be, there were more males amongst the Arfid when compared to the anorexia group, which is not surprising, partly because there's not a lot of programs that treat men. The predominant subtype we saw was Arfid aversive, and that's probably because they're more likely to reach treatment because they have a sudden worsening, usually after whatever the stress event is. 1/3 were mixed type, not surprising. A significant proportion were vomiting, which is probably a reason for admission too. And up to a third had been tube fed in the past. That's a very high proportion. And they had a somewhat slower rate of weight gain, but they did gain weight and a similar discharge BMI. Irina Vansula looked at our adults and did, in a case control comparison, found very similar differences for the adult cohort and very similar rates of weight gain. You can see here that both for adults and adolescents, the Arfid groups gain slower but equally, whether adolescent or adult. And then finally, just a word about pharmacology. You heard from our patient that he felt the mirtazapine helped his appetite. Other things that have some evidence, again, this is only case studies or case series, are olanzapine, cyproheptadine, which was tried with him but did not work, erythromycin, because it increases GI motility. D-cycloserine was used in that initial I Eat infant study and maybe increased bite acceptance. We don't know anything about psilocybin, but there's some curious and interesting case reports by individuals who think that that helped them. Of course, that might be something to study. Obviously, GI meds might help, and anti-anxiety meds, since anxiety is the most common comorbidity. So finally, we have a lot more questions than answers, and but this is a really important area to be researching, and these patients really need help and can respond well to treatment. Okay, thank you. I think I'm out of time.
Great presentation, Dr. Guarda. Let me ask you this. This low appetitive drive subtype, which our patient has today, is that something that you see in anorexia? I don't think of anorexia as having low appetitive drive. Is there a subset of people with anorexia who would fit that description?
It's very hard to know what their experience is because patients typically say they're not hungry. Many of them do. But we do see this, there is definitely a subset that has this pre-morbid history of picky eating and low weight. So I would say yes, there is a subset that, and that's been described historically too, that they were always called picky eat. It was called picky eating pre-Arfid, but they were often underweight since birth.
And do they tend to respond well to mirtazapine?
I don't.
Remeron?
Oh, we've used it. There's no studies. No studies that have picked that group.
Okay. Other folks have questions, Dr. Redgrave?
Thanks, Angela. That was a great overview of a poorly understood condition. But that was great. And as you were talking, I was just reflecting on, to kind of piggyback off what you guys were talking about, which is that, to me, the phenomenological kind of distinction between the typical eating disorders and the Arfid, it really is the drive. That is, in anorexia and bulimia, there really is a drive towards something. Whereas that is a drive for thinness, as it was first described in Gerald Russell's paper on bulimia. And it just seems to me that this group of disorders really is different, which may explain in part why we are skeptical when someone who has a history of anorexia and then presents with a sort of stated Arfid. It's very hard to imagine that drive just went away in the course of illness, because often it seems to have been reawakened. Anyway, so more.
Yeah, no, I think that's a very good point, that we see more avoidance. It's more like anxiety in some ways, in terms of the behavioral spectrum, than motivation to not eat. Yeah.
One last question, Dr. DePaula.
I wanted to ask Angela, in patient market, my experience on my work is about the cases, of the people who are post-gastric bypass, how they would be seen as either anorexic or Arfid. And I would ask also the other group to discuss the conscientious objectors. And so how was...
Okay. So the first group you're asking about is post-bariatric surgery. There is a small proportion of patients who lose excessive weight. All the ones I have seen, and I mean, in my career I've seen maybe 15, have had fear of fatness. So they would fit more into a classic eating disorder than into Arfid. I have not seen any that developed food aversions that are more textural or describe just driven low appetitive drive. They always have body image too, usually. The other group, the conscientious objector, so I think you mean like spiritual or some conscientious object, like a starved, like in prison, yeah. The Minnesota study. Well, the Minnesota study was actually a study of starvation done after the Second World War because Europe was starving and the Americans were trying to figure out how to help. And those men were conscientious objectors. That's why they were in the study, but it wasn't. So is that the question you're asking me about? Okay. So you're not asking me about conscientious objectors who are on a starvation diet. Okay. So in that study, what Ansel Keys did is he starved young men who were conscientious objectors and volunteered for the study to an anorectic weight, so to a BMI of about 18 or so. And they developed a lot of the rituals the ritualistic eating behaviors that we see in anorexia, like savoring each bite, chewing, eating slowly, separating food, dissecting it. So a lot of what we see phenomenologically in patients with anorexia. I think you're asking me maybe, do we see the same thing in Arfid? And we do see overlap. Nobody has looked at that carefully. But like our patient, both him and his mother described problems with knowing when, over chewing. And we do see that in both groups, anorexia and Arfid. We see pocketing, like keeping food in your cheek sometimes in both groups, or nibbling. And so some of the behaviors probably occur in both groups. Are they a product of the starved state? That's a very good question. I don't know. I don't think, no one's looked at that yet. So we don't know.
Thank you. Thank you. With that, we're going to wrap up. Thanks so much for a great round.